So guys, let's start with the third nerve. Third nerve or oculomotor nerve, we already seen the nuclei of the third nerve, the two major nucleus, that is the motor nucleus of oculomotor nerve and Edinger-Westphal. They were both present in the midbrain. So regarding the nuclei are present in midbrain, and the important thing is at the level of superior colliculus. At the level of superior colliculus. So even if you don't remember what is superior or inferior colliculus, let's wait for it in the neuro part. Midbrain section is discussed at two levels. One is at the level of superior colliculus, one at the level of inferior colliculus. There has been question in the past in which they gave a transverse section of the orbit. One of the muscle there was marked like medial rectus or any other muscle is marked. And the question will be asked like that, the nerve supplying the following muscle will have its nuclei at what level? So not only we have to identify the muscle in the image, we need to know that what nerve will supply it. We should know where is the nuclei, like in the midbrain, and where exactly in the midbrain it is at the level of superior colliculus. So third nucleus and Edinger-Westphal nucleus both are present at the level of superior colliculus. Fourth nucleus, which we'll discuss next, will be at the level of inferior colliculus. Once again, before going into the nerve, now this is the point where I want to discuss the columns for these nerves. Before starting with the nerve, let's talk about the columns. How many columns, cranial nerve nuclei column we have for third nerve? Well, GSE column definitely belongs to the third nerve. We know the somatic because it is supplying extraocular and tongue muscle. So because of the supply to the extraocular muscle, GSE column definitely is there. Then Edinger-Westphal also belong to third nerve, and Edinger-Westphal, if you remember, belongs to GVE column. So GVE column is because of which muscles? That is because of the sphincter pupillae. And ciliaris, which is obviously supplied by the Edinger-Westphal nucleus. Generally, that's what we said. We have two columns. Generally, we say we have two columns for the third nerve. But if you are going for the PGME, then obviously there is one more column which can be added to it. Although we say third nerve, fourth nerve, sixth and 12th nerve, these are purely motor nerves. But the thing is, there is nothing called as purely motor nerve. Either we have sensory cranial nerves or we have a mixed cranial nerves. So like third nerve is supplying extraocular muscle, like superior rectus and levator palpebrae superioris and other muscles. Now, whatever muscle they will supply, from the same muscle, they will also take proprioception. Although that proprioception is given to trigeminal nuclei, but because they're carrying proprioception from those muscles, so the proprioceptive information is also, the column of the proprioceptive information will also come here. What was the column for proprioceptive information? That was GSA. Remember that mesencephalic nucleus, big mesencephalic nucleus, which is in the GSA column. So GSA column is here because this third nerve is carrying the proprioception from extraocular muscle. It is carrying proprioception from extraocular muscle. I repeat again what I'm saying. These two columns definitely, every single book you'll find they say usually we have two columns for third nerve, GSE and GV, proving that it is a motor nerve. But in some of the textbook of neuroanatomy, they've even mentioned GSA because a third nerve, and for that matter, any other cranial nerve supplying extraocular muscle, they also take the proprioception from the same muscle, and that's why an afferent column is also to be included here. Now, let us first put up a platform on which we can discuss the third nerve, guys. For any nerve which is coming from posterior cranial fossa, whether third, fourth or sixth, and reaching the orbit, like there are 2-3 entities in between. The nerve starts from the posterior cranial fossa, will go forward. In the middle cranial fossa, they will find out the cavernous sinus. So these third nerve, fourth nerve, sixth nerve, they all have some relation to cavernous sinus. We'll see. Once they leave the cavernous sinus, they enter in the orbit through superior orbital fissure. And once they reach the orbit, then they will supply the respective muscle. So I want you to just draw this plot with me. Starting from very much left side of the page, let us say this is a midbrain. Let's say this is a section of the midbrain taken at the level of the superior colliculus. That's a midbrain section taken at the level of superior colliculus. Here are the superior colliculus. These colliculus are the nuclei present in the dorsal part of brainstem. I'm just writing in short, guys. This is, let's say, SC, that is superior colliculus. We'll be discussing the parts of the midbrain in the neuroanatomy, but the portion which I've highlighted here, the portion which I'm highlighting here, this portion of the midbrain, the ventral part of the midbrain, is called as cerebral peduncle. We can call them crus cerebri or cerebral peduncle. I should write that also. This here is called as a cerebral peduncle. So if these are the two cerebral peduncle, so the fossa that we have in between, the space in between should be called as what? Interpeduncular fossa. It's a space between the two peduncles and we call it interpeduncular fossa. Let's say we have a third nucleus here. This is a third nucleus of the right side and there's a third nucleus of left side. And that's what the speciality of the third nucleus is. Both side nucleus, they are fused in the midline. The two nucleus, one we have third nucleus of right and the left side, but they're fusing in the midline. And we have a Edinger-Westphal nucleus. Let's say if I just put it at some distance here, just for the sake of reference, that is Edinger-Westphal. Do find out space to label them. This is the third nerve nucleus, the motor nucleus of third nerve. That's the motor nucleus of third nerve. And let's say this here is the Edinger-Westphal. Right? So that's the part of brainstem that we need from where the third nerve will begin. You're looking at the section of the brainstem where in the midbrain, what level? At the level of superior colliculus. What you see there? You see there are two third nerve nucleus obviously present, bilaterally present, but they're fusing in the midline, which is having some clinical significance also. And then we have two separate Edinger-Westphal nucleus as well. If I go beyond, then we said we got a cavernous sinus. So let's say, guys, this here is the cavernous sinus, which is in the middle cranial fossa. There is the cavernous sinus. And you go beyond the cavernous sinus, we got a fissure here, that is a superior orbital fissure. In fact, the anterior relation of cavernous sinus is superior orbital fissure only. This is the cavernous sinus. And here we got the superior orbital fissure. And finally, we will be reaching the eyeball where all these muscles are to be supplied. Where all muscles except SO4 and LR6. So rest all the muscles I need to mark here. So we got a superior rectus, which is overlapped by this LPS, levator palpebrae superioris is there. This is medial rectus. We got inferior rectus. And let's say here is the inferior oblique. Inferior oblique, inferior rectus, medial, superior and LPS. So that's the kind of, more or less, that's the kind of plot we'll need for other nerves also. We'll be looking at a brainstem, then cavernous sinus, then superior orbital fissure, and ultimately getting inside the orbit to supply the respective muscles. How the third nerve originates? Now, originating from their respective nuclei, guys. Originating from third nucleus, the third nerve, first of all, when it comes out on this fossa that is called as interpeduncular fossa. So when you see the third nerve comes out here, let me stop here. When the third nerve comes out, it is coming out from between the two peduncles. So first point to be noted here is the third nerve is the content. It's the content of the interpeduncular fossa. It is the content of interpeduncular fossa, which is having a very important significance. We'll come to that. As soon as the nerve leaves the interpeduncular fossa or it leaves the midbrain, it passes between the two branches of basilar artery, the two terminal branches of basilar artery. And those two branches are, now what is the terminal branch of basilar artery? We have posterior cerebral, let's say this is PCA, posterior cerebral artery. And the artery which is just proximal to PCA is superior cerebellar artery. Superior cerebellar artery. Both are the branches of basilar artery. The basilar artery divides into posterior cerebral, and just behind that we have superior cerebellar artery. And you see third nerve is passing exactly between the two arteries. Then the third nerve, when it reaches the cavernous sinus, what is the relation with cavernous sinus? It is not going inside. The third nerve is adherent to the lateral wall. So you can see the third nerve is crossing and it is adherent to the lateral wall of cavernous sinus. Another important information which will be needed when we'll talk about the relations of cavernous sinus. In the lateral wall of cavernous sinus, we have third nerve. But guys, third nerve, before it goes into superior orbital fissure, it divides into two divisions. We have upper division and the lower division is seen here. The upper division will obviously go and supply the upper two muscle. It will supply the LPS and it will supply the SR also. It will supply the levator palpebrae superioris and superior rectus. Whereas the lower division will take care of the remaining three muscles. It supplies medial rectus, it supplies inferior rectus, and it also supplies inferior oblique. So this, let me write, this is UD, that is upper division, and this is LD, that is lower division. Upper division supplies two muscles, superior rectus and LPS, and lower division remaining three muscles. And out of all the muscles, all these muscles in here, medial rectus is the one which you need to specially keep an eye on, because upper division will be supplying the upper two muscle. Makes sense. Lower division will supply the inferior rectus, inferior oblique. Again, that also is easy to remember. But medial rectus you have to remember. Medial rectus is by lower division. That's the point to take away from here. Even more important thing is here is Edinger-Westphal. Now, we said Edinger-Westphal will supply sphincter pupillae and ciliaris muscle, and it will use the third nerve to reach there. Now, how exactly it will use it? Before I draw the pathway, let me tell you, Edinger-Westphal fiber will join with the third nerve. They will keep running in the third nerve only. Then they decide to go with the lower division of third nerve. And then they decide to go with the nerve supplying the inferior oblique muscle. And they finally separate from here and goes into their respective ganglion in the orbit called as the ciliary ganglion. Let me draw that pathway for you. I'm using a different color for it. So guys, let's say the fiber starting from the Edinger-Westphal, they are going along with the third nerve only. Then they move along with the inferior or the lower division. And then finally you see them going with a nerve to inferior oblique. And from there they separate and they go into the respective parasympathetic ganglion. And what is that respective parasympathetic ganglion? That is the ciliary ganglion there. I'll tell you the location of the ciliary ganglion separately. That's a ciliary ganglion. That is how Edinger-Westphal, these parasympathetic fibers from the Edinger-Westphal, they reach the ciliary ganglion using the nerve to inferior oblique. That's again an important information, that fibers to ciliary ganglion, they reach the ganglion via nerve to inferior oblique. They might ask you guys, which nerve carries the fiber specifically to ciliary ganglion? That is nerve to inferior oblique. Nerve to inferior oblique. And from the ciliary ganglion, now we got all these short ciliary nerves coming out. All the short ciliary nerves comes out of the ciliary ganglion, and they are the one which supplies the sphincter pupillae. They supply sphincter pupillae and ciliaris muscle. They supply the sphincter pupillae and ciliaris muscle. Dilator pupillae is supplied by the sympathetic nerve. I can tell you the same thing here so that you don't forget that. Sphincter pupillae and ciliaris. Please remember that it's only sphincter pupillae and ciliaris. Sphincter pupillae and ciliaris. Just an added information here so that you don't forget it. Dilator pupillae. Dilator pupillae has nothing to do with the cranial nerves. Dilator pupillae is supplied by, now what will happen from the spinal cord? From the spinal cord, the sympathetic nerve will originate. The sympathetic nerve somehow will reach the superior cervical ganglion. Let's say this is the superior cervical sympathetic ganglion. We know sympathetic chain in the neck region is having three ganglions, superior, middle, inferior. Sometimes instead of inferior we have stellate. So superior cervical ganglion, and from the superior cervical ganglion the post ganglionic sympathetic nerve will come out, will make a plexus around some artery. Let's say it's ophthalmic artery. Let us say it's ophthalmic artery. So post ganglionic nerve will come out from here. It will make a plexus around this ophthalmic artery. And then the post ganglionic fibers will reach what muscle? The dilator pupillae muscle. So sphincter pupillae is supplied by Edinger-Westphal using the third nerve. And I just told you that how dilator pupillae are to be supplied. They are supplied by the sympathetic nerve. Where it is coming from? The post ganglionic fiber are seen coming from superior cervical ganglion, making a sympathetic plexus around the ophthalmic artery. and then ultimately goes to supply the dilated pupillae. Okay. Now, what all important information we can fetch from here? Like we already said, the third nerve is a content of what? It is a content of interpeduncular fossa. It is a content of interpeduncular fossa, and because the nerve is coming out between the two major arteries, we saw that the nerve emerges between. The nerve emerges between what two artery? It was PCA, posterior cerebral artery, and superior cerebellar artery. Now, this location of the third nerve makes it vulnerable to the aneurysm also. Third nerve is the content of interpeduncular fossa. And in the same interpeduncular cistern, we have posterior part of circle of Willis. Now, what is there in the posterior part of circle of Willis? PCA is one of them. Posterior cerebral artery, we all know, it contributes to the circle of Willis also. So, if PCA is there and PCA is also having a posterior communicating artery, let's not go into that part in detail. So basically remember that we have a posterior part of circle of Willis in the same fossa, in the same interpeduncular fossa in this region here. And third nerve is coming out of it here. So the aneurysm which involves this region or the posterior part of circle of Willis, the most commonly involved nerve will be the third. The most commonly involved nerve will be the third nerve. So you can note that because of its anatomical location, the third nerve is most commonly involved in intracranial aneurysms. Intracranial aneurysms. There also, I remember a question asked in 2014. The question was that they gave the names of the muscle like superior rectus, LPS, medial rectus. I mean, all the muscle which are supplied by third nerve only. But the question was asked that which of the muscles supplied by the third nerve, but not the ipsilateral third nuclei. It is supplied by third nerve, but not the same side third nucleus. See, what is the answer to that question is, guys, we said that third nucleus of the right side and the third nucleus of the left side, they are fusing in the midline. Let's say that's how it is. If I just draw it as a midline here. So this is the motor nucleus of third nerve here, and that's a motor nucleus of third nerve here. So, and both the nucleus you can see are fusing in the midline here. Well, undoubtedly the nerve fiber which will come out of it, those nerves will go to their corresponding side and supply the muscle of that side only. The right side fiber will go and supply the right side extraocular muscles. Left side fiber will go and supply left side extraocular muscle, except one. And that muscle is what? That is superior rectus. Now those fibers which are supplying superior rectus, they originate and then they decussate to the other side and then go and supply the superior rectus of the contralateral side like this. So those superior rectus muscle, it is supplied by the same side nerve. I mean, if you look at that, if let's say it is a right side third nerve, the right side third nerve is supplying right superior rectus, but not the right side nuclei. The nuclei is present on the contralateral side. So nuclei is present on the contralateral side. So it's important to note that superior rectus is the muscle which is supplied by contralateral third nucleus. Not contralateral third nerve, contralateral third nucleus. Opposite side third nucleus here. Which gives rise to one question here, that if let's say the question says there is an injury to third nerve or if there is injury to third nucleus, what difference will be there, guys? If let's say there is an injury to third nerve here, let's say this is a third nerve injury. This is third, let me write the full thing, that is a third nerve injury. Then obviously everything is involved on the ipsilateral side. So it's all ipsilateral involvement. Everything is ipsilateral involved. Ipsilateral extraocular muscle, including the same side superior rectus also. So it's a ipsilateral involvement is there. But yes, if the question says there is a third nucleus injury is there, not the nerve, nucleus. So in case of nucleus, third nucleus injury, what difference we'll see, guys? The difference will be, obviously, if a third nucleus is involved, again we have ipsilateral extraocular muscle involved. But what about superior rectus? Well, superior rectus of both sides will be involved. Why both sides? Because the fiber which are coming from opposite side are also involved because they're coming from inside the nucleus only. Look at that. If you look at these fibers, they're coming on this side only and then coming out. So they are affected. And the one which are originating here and going on to the other side, they are also affected. So despite of having an injury to only one side, superior rectus involvement will be there on both sides. So that's the point here, that we have ipsilateral extraocular muscle involvement, but bilateral superior rectus involvement will be there. Rest of the extraocular muscle are involved only of the same side, but superior rectus of both sides will be involved. So that is the speciality of this third nucleus, because it's fusing in the midline and the fibers of superior rectus are kind of decussating inside and reaching the other. Overall, if there is a third nerve injury, guys, what are the features? I mean, what are the clinical features that you will see in the injury to third nerve? If there is a third nerve injury, let's take the important muscle supplied by third nerve and that will get the answer to us. Like obviously LPS is gone. So if levator palpebrae superioris muscle is involved, there will be ptosis. And ptosis of what side? Ipsilateral. If right side third nerve is gone, right side LPS is gone. So it will be ipsilateral ptosis. Medial rectus is also gone. Medial rectus is supplied by third nerve. And because of medial rectus is gone, but lateral rectus is working, which is supplied by the abducens nerve. Because lateral rectus is working, so there will be ipsilateral divergent squint. Ipsilateral divergent squint will be there. Ipsilateral divergent squint will be there. The eyeball will be abducted on the same side. Now, once again, if I write the name of the medial rectus, just for the sake of convenience, guys, medial rectus plus superior rectus plus inferior oblique. If you look at the collective effect of the injury to these muscles, medial rectus, superior rectus and inferior oblique, we know that superior rectus and inferior oblique both are to look up. Superior rectus and inferior oblique are to look up, and medial rectus to look inside. So there will be opposite of it. So the eyeball will be down and the eyeball will be out. We already said out, that is divergent squint, and that's why in third nerve injury we usually say that third nerve injury leads to the ipsilateral down and out eyeball. Ipsilateral down and out eyeball. Ipsilateral down and out eyeball because of the third nerve palsy. Right? Sphincter pupillae. Edinger-Westphal fibers are also affected because of the third nerve. So sphincter pupillae is involved, and involvement of sphincter pupillae will lead to what? It will lead to the dilated pupil. Why it will lead to dilated pupil? Because dilated pupil is still working. It is supplied by the sympathetic nerve. So there will be a dilated pupil. And loss of light reflex. The sphincter pupilla is affected, so there will be a loss of light reflex. And finally, ciliaris muscle is also affected by the third nerve injury, and involvement of ciliaris muscle will lead to the loss of accommodation. Loss of accommodation reflex. So these are some typical features of the third nerve injury. We got a ipsilateral ptosis, the divergent squint, down and out eyeball, dilated pupil, loss of light, and the accommodation reflex. Easily justified by looking at what exactly third nerve is supplying. Chalo, from here on, let's move on to the fourth nerve, the trochlear nerve. Now, knowing all this, now let's talk about the fourth and the trochlear nerve. Guys, the trochlear nerve, again, if you look at the stations there, it's got to start from the midbrain. We got to go to the cavernous sinus, the superior orbital fissure, and then one muscle in the eyeball, that is superior oblique. But this time the difference is the section of the midbrain should be taken at the level of inferior colliculus. So the fourth nucleus is present. If you talk about nucleus, the fourth nucleus is present where? In midbrain at inferior colliculus level. at the level of inferior colliculus or at inferior colliculus level. Third was at the superior colliculus, it is at the inferior colliculus. Once again, if I talk about the columns, think about it. Fourth nerve is supplying muscle that is superior oblique. Extraocular muscle comes under GAC. So the one column has to be GAC once again. Why GAC? Because it is supplying superior oblique, which is an extraocular muscle which comes under somatic muscles. And again, we have to add GSA here because the same fourth nerve is carrying proprioception from superior oblique. It is carrying the proprioception from superior oblique. So GSE, and again, majority of the books of new anatomy, they say one column only, that is GSE. But as I said, many neuro authors, they believe that GSA column should also be counted because it is carrying the proprioception from superior oblique. Let's draw the pathway for this fourth nerve. Now, once again, we are looking at a section of a midbrain. And this time the section is taken at the level of inferior colliculus. So just make sure I write IC over there as inferior colliculus. These are once again the cerebral peduncle. We don't have to label them again. That is cerebral peduncle. Now the difference is, when you saw the third nucleus, the right and left nucleus were kind of fusing in the midline. Not here. The fourth nucleus, they are present separately. The right and the left nucleus, they are separately placed like this. So that's the fourth nucleus of the right and the left side. Rest of the story is same. We got a cavernous sinus here. We got superior orbital fissure again. And just one muscle to be supplied this time, and that is the superior oblique muscle. Here's cavernous sinus, and that is the, once again, SOF I'm writing for superior orbital fissure. See, everything important about fourth nerve is to be seen in the beginning only. The majority of the questions which are worth asking are there in the beginning part. First of all, fourth or trochlear is the only nerve which is coming from the dorsal aspect of brainstem. So how you will see the nerve coming out? The nerve will start and then decussate within the midbrain and emerge like this. So that's the first thing. Make sure when you draw it, the decussation that we're looking at should be inside midbrain. The decussation over there, it is present within the midbrain, not outside. Many Google images have shown this incorrectly, where they've shown the decussation is outside. No, it is inside the midbrain only. And then the nerve is winding around the entire brainstem like this. On the peduncle also comes like this, again running in the lateral wall of cavernous sinus through superior orbital fissure, and ultimately goes and supplies the superior oblique. So here relation, no change. That is, again, it is in the lateral wall. Just like third nerve, it is also in the lateral wall. Just like third nerve, it is also present between the same two arteries, the same two terminal branches of the basilar artery, and those were PCA, the posterior cerebral artery, and superior cerebellar artery. Superior cerebellar artery. So no changes in that. So what I've said, that everything important about the fourth nerve, the things which are noteworthy, are seen in the beginning itself. Now what you're looking at from this diagram, guys, that first of all, the nerve is coming from the dorsal aspect. So it's the only nerve, only cranial nerve emerging from dorsal aspect of brainstem. From the dorsal aspect of brainstem. Right? That's one thing. If a nerve, then secondly, the lower motor neuron that you're looking at, obviously there are lower motor neuron. After the nucleus, it will be lower motor neuron. The lower motor neuron, they are decussating, and then they are emerging out. No? So that the lower motor neurons, they decussate. They decussate where? Again, within brainstem only. The lower motor neuron, they decussate within brainstem. within brainstem. So one important thing is it is from the dorsal aspect here. And the second important thing you're saying that lower motor neurons are decussating here. Usually when you talk about any cranial nerve, we talk about their upper motor neurons are decussating. Like facial nerve, upper motor neuron decussates. But here it's the lower motor neuron which are showing the feature of decussation. And what happens is a nerve first decussates, come from the dorsal aspect, winds around the brainstem, and then goes forward into cavernous sinus, which makes this nerve to have a longest intracranial course. The fourth nerve is having the longest intracranial course. Longest intracranial course. Be careful with the word, guys. Intracranial, not intradural, not intraosseous, not the longest nerve. It is the longest intracranial course now that is having in the fourth nerve. And finally, fourth nerve is the thinnest cranial nerve. Either you call it thinnest, or you can call it the most slender. Thinnest is slender, most slender, or you can even call it the smallest cranial nerve. It is the thinnest, most slender, or the smallest cranial nerve. Now, smallest is the word which makes some people raise their eyebrow that how come it is the smallest nerve? Because when you say the word smallest, people usually think of the olfactory. Well, guys, olfactory is not the smallest cranial nerve. Olfactory is the shortest cranial nerve. Difference. That is the shortest, this is smallest. So when you talk about the smallest and largest, you're talking about the thickness of the nerve. When you say shortest and longest, then you're talking about the length. So like shortest is olfactory and longest is vagus, right? But when you talk about the smallest and largest, smallest is this one, the fourth nerve, and largest is trigeminal. That's about the thickness. So thinnest nerve or the smallest nerve is trochlear, but the thickest nerve is going to be trigeminal. So here it is corresponding to the thickness and not to the length here. So that's about the fourth nerve, guys. The fourth nerve, which is coming from the dorsal aspect and winding around the brainstem. So all these that we're discussing here, this will aid us in the neuroanatomy part also, because in the neuroanatomy, if I draw a section of the brainstem for you and we look at from the posterior aspect, the nerve that we'll see coming from around the brainstem and then reaching backward is the fourth nerve. So whatever we're discussing here will definitely going to aid in the neuro part. With that, coming to the third and the last nerve in this category, supplying the extraocular muscle. We're done with the third, fourth, and now we'll talk about the sixth nerve first. We'll take the fifth later. So coming to the sixth nerve, the abducen. Same question, where will you find the nucleus? So think about when we discussed the brainstem column, where was the nucleus for the sixth nerve? Guys, sixth nucleus is present in pons. It was present in the pons. And at the level of, now this time what is the special thing about that level? At the level of facial colliculus. At the level of the facial colliculus. So the brainstem, where it is coming out, that is pons, and the level is the facial colliculus from where the sixth nerve will come out. Now, what is facial colliculus? Although we'll discuss facial colliculus in the seventh nerve, facial colliculus, the facial nerve is winding around the sixth nucleus and comes out. I hope you all know about the internal genu. If this is the sixth nucleus, and let's say this is the seventh nucleus, so seventh nerve is having a property to turn around and comes out like this. So that bulge which is formed in here, this bulge which is formed here around the sixth nucleus, this is called as the facial colliculus. That bulge can be very clearly seen in the floor of the fourth ventricle, and we call it facial colliculus. Coming to column, again the column remains the same, the GSE column, general somatic efferent column. General somatic efferent column, why? Because it is supplying lateral rectus. It is supplying an extraocular muscle. And same story again, GSA can also be included because it is believed to carry proprioception from lateral rectus. It is carrying the proprioception from lateral rectus. So that's some introductory part about it. Sixth nerve at the level of, in the pons, present in the pons at the level of facial colliculus, and we have the two columns related to it. If you have to go with one column only, the first column is your definitely best answer. But if you are asked to have a multiple answer, something like that, you can go with the GSA also. Let's draw the plot for the sixth nerve. Now this time the things are a bit different because see, it's important to understand the third and fourth nerve, they were coming from the midbrain. Whether it is superior or inferior colliculus, but it was midbrain, and then they were going toward the cavernous sinus. Now cavernous sinus and midbrain are at the same level only. So the nerve just have to go straight into it. This time the sixth nerve will come from pons. Pons is slightly below. If pons is slightly below, that means the nerve first has to ascend upward, reach the pons, reach the cavernous sinus, and then goes inside. And that's why there is an obliquity that you see in the course of the sixth nerve. It's not going straight into the brainstem or straight into the cavernous sinus from brainstem. It is coming out obliquely from the brainstem and going into cavernous sinus. So let us say if this here is pons, just make sure to draw the cavernous sinus slightly higher. This is the cavernous sinus. And rest the same thing. Superior orbital fissure. And the muscle to be supplied, that is lateral rectus. Okay. What we already mentioned here, that facial nerve nucleus will be there. Facial nerve nucleus is there, and facial nerve like winds like this and then comes out from pontomedullary junction. So we'll see that later. This is the facial nerve. And it is winding around the sixth nucleus only. So that, let's say, is the sixth nucleus. So it is winding around the sixth nucleus. So let's say the sixth nerve which ascend upward to reach the cavernous sinus, and then it goes inside the cavernous sinus. It goes inside cavernous sinus, unlike third and fourth nerve, through the superior orbital fissure to the lateral rectus. So one important difference you see here is that this nerve is not in the lateral wall. The sixth nerve is present inside the sinus. Second important thing, when the nerve is ascending upward to reach cavernous sinus, it is having a very, very important, a bony relation there. Petrous temporal bone, guys. We know the temporal bone is having a squamous part and petrous part. The petrous part is forming the middle ear cavity and all that, and petrous part is mainly facing inside the cranial cavity. So petrous part is having an apex, which I'll show in the osteology region. So there is an apex of petrous temporal bone which is in close relation to this nerve just behind cavernous sinus. So let's say it's a part of a petrous temporal bone which is very sharp. It is the apex of petrous temporal bone. Apex of the petrous temporal bone, and to that apex we have the sixth nerve related here. Close to the apex of petrous temporal bone, there is a ligamentous canal which is present here. There's a canal which is made up of ligament, guys. There's a canal here. They've asked this question twice about this canal. This canal is called as a Dorello's canal. This canal is called as the Dorello's canal. That's a Dorello's canal. So it's another very, very important information that sixth nerve, it passes through this ligamentous canal called as Dorello's canal. And let's say if the question is asked that which ligament forms the Dorello's canal, the ligament is called as a petroclinoid ligament. It's coming from the petrous part of bone and it is going to the clinoid process of sphenoid bone. So petroclinoid, or you can call it petrosphenoid also, because clinoid process are the part of sphenoid bone. So this ligament here is called as a petroclinoid ligament. You can call it petroclinoid, guys, or petrosphenoid, same thing. Petroclinoid ligament or petrosphenoid ligament. We can understand these ligaments only when we have the picture of the skull with us. And there the canal is present through which the sixth nerve is passing, and then inside the cavernous sinus. Looking at this nerve, one thing which you can make out from here, the nerve, because it runs obliquely and then goes inside the cavernous sinus. So once the nerve comes out of the dura mater, it again goes inside the dura mater. So from the dura to the dura and then again comes out. That's why the nerve is having a longest intradural course. If it was not going inside the cavernous sinus, it may not be having the longest intradural course. So it leaves the dura mater and then again inside the cavernous sinus it goes where it is cavernous sinus is a durameter only. That's why the nerve is regarded to have the longest intradural course. Longest intradural course. Longest intracranial was 4th. This is intradural. 6th is longest intradural. And see something very, very important to understand. If there is an increased intracranial pressure, now if the condition is there is an increased intracranial pressure. What happens? What is the response of the brainstem to the increased intracranial pressure? The brainstem try to descends down. The largest foramen magnum, and let's say if this is a medulla oblongata, which is like coming out of this the foramen magnum here. So if there is an increased intracranial pressure, that will push the brainstem down like this, right? The more the brainstem will descend down, that is pons is also descending down, this nerve will get stretched. The brainstem is descending down, the nerve will get stretched, and unfortunately it is related to the apex of petrous temporal bone, where it can get injured also, because it's very sharp margin. That's why if the question is asked the most common nerve to be involved in increased intracranial pressure, the answer has to be 6. So most commonly involved in increased intracranial pressure. Now I've said this, okay, this is most commonly involved in the increased intracranial pressure, but the point is if that increased intracranial pressure is present bilaterally. If it is a bilateral increase or there is an overall increase in the cranial cavity, then only the brainstem will descend downward. Na? If it is a unilateral, or if it's, let's say, on one side, if there is an increased intracranial pressure, then brainstem is not going to descend down. It will be pushed to one side. If there is an extradural hematoma, let's say there is extradural hemorrhage is there on the right side, so obviously the entire brain and the brainstem will be shifted toward the left side. In that case, 6th nerve is not the most commonly involved. The nerve which was coming out of interpeduncular fossa is most commonly involved because of its anatomical relation. So which nerve was that? That was the 3rd nerve. So please be careful, guys. If the question simply says increased intracranial pressure, then we have to presume it is bilateral. Or they might give you bilateral in the question itself. Or if they say that there is an intracranial pressure increase because of the hemorrhage, extradural hemorrhage, then obviously you have to consider it unilaterally. In that case, 3rd nerve is the most common. So you can go back to the 3rd nerve and you can write that 3rd nerve is most commonly involved in ipsilateral increase in intracranial pressure. I repeat again, 3rd nerve is most commonly involved in ipsilateral increase of intracranial pressure. Ipsilateral increase of intracranial pressure. So this is about the 3rd nerve, the 4th nerve and the 6th nerve, the 3 nerve which are supplying the extraocular muscles. Now from that we have to move on to the next nerve, that is the 5th nerve or the trigeminal nerve. Now guys, before we talk about the trigeminal, we have to understand concept behind the parasympathetic ganglion, because all the parasympathetic ganglion have some relation to the trigeminal nerve. So let's have an overall look at the parasympathetic ganglion, and from there we can move on to the trigeminal nerve.